We move on now to the next item, which is item 12, primary care support services. Barbara, please would you introduce the paper?
Thank you, Chairman. This paper's to do two or three things. Firstly, to keep the board up to date about this programme, which I would say from the outset is an absolutely massive programme of change that we need to deliver safely, efficiently and effectively over the next 12 months. This is a service with 1,800 staff worth £100 million, and the changes are very significant indeed. So it's an update on where we are in that transformational process. I hope that it gives the board reassurance that we are managing and mitigating the risks, although they still exist quite significantly, and I think the risks for NHS England getting this process right are still significant. And most importantly, perhaps it asks you to launch a consultation with staff, which we now feel ready to initiate. So if I can remind everyone about primary care support services and the history behind why we're discussing this today, the table in one identifies exactly what they are. They are dominantly about paying independent contractors, particularly GPs, optometrists and pharmacies, but also in supporting them to do some of their processes. So where it says cervical screening and breast screening, it doesn't actually mean that these services undertake cervical screening and breast screening, but they do the call and recall system to make sure that no one is missed. So these are a key set of essential services which in the NHS over the years have been dealt with in very different ways in very many different units. So, once upon a time we had I think the biggest number of commissioning units we had was probably when we had about over 300 PCTs, and some of these are still in a legacy, so we had 300 different ways of providing and supporting these services. We decided that because these were so critical both to the payment of the contractors and to the delivering services for staff, that we would actually simply what we call lift and shift the services in the first year. There was so much change going on in NHS England in terms of our other reorganisation that it was deemed prudent not to reorganise these services at the same time. And we were able to do that because at the time the running cost reduction that, which we were obliged to make, we are now in its final year of the reduction process that we had at the time, and therefore we were able to use that slack capacity in order to leave these services at their full running costs for an extra year. But nonetheless, there was no question when we made the decision to defer that we were still committed to these services being subject to the same running cost reduction that all the other services in NHS England had been. We discussed this informally with the board some months ago when our plan was to ensure that in line with that timetable we had completely transformed these services by April 2014, and after discussion it was clear that this was too high risk for these very important services, and the board advised that we should revisit the terms of reference, which were initially largely to reduce the running costs, to say how can we ensure that these services are transformed safely, and what's the timetable to do that, still needing to get to the point whereby we do make these management cost reductions, and actually might we even at some stage be able to go beyond that? Might there be more economies of scale because of the nature changes in technology and the digital revolution? So we've re-looked at things, had many pieces of work going on, and what we're bringing to you today is some outline proposals that the regions have come up with how they might be able to make those change. There are some paragraphs 3 and 4 are critically important about the principles that we've worked in on the changes, and the table in paragraph 8 shows broadly what the four regions are proposing, with significant reductions in the number of sites and inevitably significant reductions in the number of staff working on these services throughout the course of next year. But you will PLC, not to the original timetable of April 2014. You'll notice that London and the South have one joint proposal. That's largely because the other costs in London make it almost impossible to undertake these services within the capital because of the additional market forces. So these three proposals are what we want to go and talk to staff about now, so that we can refine them, improve them, and turn them into one national proposal, one coherent proposal. I would point out that there are other very significant pieces of work running alongside at the same time. We need to make sure some of these services are already outsourced, so we need to be having the right conversations with those providers to make sure that, that they can come in line with this plan. There are some national things that we need to get in place, especially around IT, which will support the delivery of these services from their new and reduced sites. There are some aspects of the things that have been put into the bundle of primary care support services which actually aren't primary care support services. They've just, historically they've been bundled with that, and we need to understand what those are and make a decision where the responsibility for those will lie. We are, however, committed to maintaining the timetable we had, which is to bring the board in January a proposal for the change based on what has come out of the work and the consultation with staff. And the final section, which I'm sure Joe will want to comment on, talks about how we will consult with staff and how we'll make sure that what is a very difficult process for a number of staff. Many of these staff are not necessarily highly paid workers. They aren't able to move around as easily as some of the staff already working in NHS England who went through this sort of change a year ago. Some of them were perhaps more mobile if we reduced to fewer sites. So we shouldn't underestimate the impact on very many staff that this will have, and we really, really want to make sure that we get this consultation right with them and work with them to make it as the best it can be. So, Chairman, I don't know whether Joe might want to comment.
If I may invite Joe to add to that.
I'll just say a few words, if that's all right, because I think Barbara's covered most of it off. The one thing I do want to reiterate from what Barbara said is what a significant change management project this is. It is in many ways an opportunity for us to live out our values in relation to our relationship with our staff. And just to put the numbers in context, as Barbara says, there are almost 1,800 staff who work in these services. That's about 30% of our workforce. It's nearly a third of the staff we employ work in these services. And as Barbara rightly says, generally our lowest graded, lowest paid staff and our least mobile staff. So the way in which we go through this change process is going to be very significant, I think. The scale of the savings mean that there will be fewer jobs at the end of it than there are now. But the purpose of the consultation, the legal responsibility we have in the consultation, is to mitigate redundancy, so to try and keep the number of compulsory redundancies as low as possible. That's the principal purpose of the consultation. And for that to happen, the consultation has to be meaningful in the sense that we need to share the plans with the staff, we need to go into the detail, we need to be prepared to listen and to change them if staff have got better ideas for ways of saving £40 million. The 45 days is the consultation period needs to run for a minimum of 45 days under the law, but I think when we get into this, we will probably, in some areas, run for more than 45 days. You'll see from Table 2 that some of the regions are not proposing to make staffing reductions before May. So we're starting early to try and get full engagement with staff and their input into the plans themselves. I think we'll run the consultation at 3 levels. So at national level, we'll be talking with staff side, recognised trade unions about the way in which we do this, the policy and the principles that we apply to the whole change programme. At regional level, we'll be taking staff and their representatives through the detail of the plans and getting their views and giving them a chance to influence the plans. And at individual level, we'll be having conversations with every member of staff affected by this process about how it affects them and what they want to do. That is a major management undertaking. there are 1,800 staff. We need to have at least one meeting, probably more with all of them. So it's going to take up quite a lot of management time. I don't propose any more at this stage, if that's okay. I think the board's going to have the opportunity to discuss this again in subcommittees and in public in January. So.
Well, thank you very much, Joe and Barbara. I mean, we shouldn't underestimate the sheer scale of this. And I think the thing that worries me most is maintaining a continuity of service and improving the quality of the service that we provide to primary care through a process of quite significant disruption of the jobs of those who are involved in it. We talk in here about resorting to new ways of working and to new technologies to carry through the services, and I'm just interested to know how we can ensure that we use this as an opportunity in relation to such areas as medical records, for example, and transfer of patients to advance our own efficiency as an organisation and to deliver higher quality to those who are at the receiving end of these services.
I mean, certainly, interestingly, I think that the independent contractors have perhaps been more digital and more computer systems than many other parts of the NHS, and a remarkable amount of this is already computerised. And in fact, one of the significant streams that we've got a dedicated individual helping us on will be ensuring that the Exeter system, which is, on which a lot of this is based, can be successfully implemented in the new sites. But I do think there is much further to go, and potentially, in the longer term, a way of streamlining and making it a much better and a more efficient service. I think in the first instance, it's really important that we get through this current change process and keep everything as safe as we can be. And we will need to work very hard with stakeholders, because not surprisingly, not only the staff extremely anxious about this, but also the independent contractors making sure this service is right for them. But I think that this will be, it won't end there. There will then be, there will always, I think, be the opportunity to do this in a better way as technology improves. So it's looking at Tim.
Tim may want to come in a moment. Let me turn to Ed.
Yeah, Malcolm, I mean, there's no doubt that we need to do this, and that we need to get to the lower cost of delivery. This is ambitious. The timescale and the size of this, and I said to David as we were coming in, the private sector would only do this in extremis, and they would have a lot of resource underpinning it. And quite a lot of oversight to make sure that it happened. And at the moment, I haven't got that level of detail, and I welcome it's coming back in January. But I do just wonder whether perhaps a little more formalised task and finish group with an odd non-exec, and I'm certainly not volunteering at this stage, might be helpful, because this has high visibility, it's high numbers of people. In the scale of our total cost base, it's not. It's relatively modest. But your point about sustaining the service in the new environment is equally critical. And I think it's probably quite a high-risk project. And having had one or two of those in our history and in probably our histories in other parts of organisations, that level of oversight, I suspect, would be helpful.
And if I might add to that, Chairman, I think that would be very helpful. Two things. Firstly, we have recently very significantly increased the resource to manage the programme. But what I also think we need to do is to make sure we've got the right external assurance in place. So as well as the task and finish group, we've got a gateway review on it. But I would, if the board was happy, I would welcome the opportunity to seek a significant external assurance for what we're doing.
Can I just say just a couple of things? I think Ed is absolutely right. I think it would be helpful to have non-executive oversight in some way to all this. It would help us, I think, get through all of this. But just two points. One of them is that we're trying to get down to what's the price per
£1.08.
£1.08. But there are places in the country who do it at that price and below that price now.
67 pence, that sort of 60
Yeah,
something
yeah.
pence.
So,
the
so
lowest.
the point I make, it is possible. So it's not a complete, you know, it's not, we haven't picked this out. It is possible to do it. And secondly, in terms of, you know, we're going to have a discussion in December about allocations. This will create another £40 million to allocate for patients. You know, so it is important to do it, as well as understanding the risk and all the rest of it. It is an important thing for us to do.
I was careful to say ambitious, not heroic.
Yes, yes, or courageous,
Or
or
brave,
what have you.
yes.
About, yeah.
But I think the critical thing, though, as far as our staff is concerned, is that this was business left over from the reforms, and we want to make sure that there is no disadvantage to staff in the way in which we handle this process over the way in which those other staff were handled during the process of the health reform. So can I then ask the board if they're willing to endorse the direction of travel for the programme, to establish an informal task and finish group, and to keep a close eye on resources to ensure that the activity is adequately resourced. Okay? Thank you all very much for that. We now turn to an item which is purely for information, which is on the use of the company seal. I don't think we need to say anything about that, and unless anybody wishes to institute a probing discussion of it, I think I'll move on very quickly. And we then have other business. The only item that I have got is the date of the next meeting, which is to be on the 17th of December and will be held in NHS Southside in Victoria Street in London. Are there any other items of other business? No. In which case, thank you all very much. The board itself will now move into private business, but may I thank everybody for their attendance this morning.